Good morning, ma'am. We are Group 2. Our patient's name is DCL. She's 18 years old. Birthday is on June 18, 1999. She's single and lives at 27th Street, Santa Mesa, Manila. Chief complaint is first natal consultation. History of present illness. 1 week prior to consultation, patient started to feel dizziness, vomiting of one episode, blurring of vision, behavioral changes such as increased irritability, increased need for sleep, aversion to favorite food, increased appetite, urination, and frequent urination. So she bought two pregnancy kits, which showed positive result twice. She has not taken any medications. Last consumption of alcohol was last February 2017. No cough but has history of colds for 3 days. No bleeding but with white discharge notes. Patient experienced persistent symptoms with one episode of abdominal pain described as similar to sinisikmura. Patient decided to seek prenatal consult. Menstrual history. Menarche 11 years old, regular menses, 28 days interval, around 3 days heavy duration. 3 to 4 pads a day with no dysmenorrhea. Obstetric history. G1 current pregnancy. Gynecologic history. She has positive UTI, 13 years old, treated with unrecalled medication. She has negative endometrial or ovarian masses, negative PCB. Sexual history. Coitarch at 13 years old. Contraception, she's using none. Immunization is complete. Health maintenance is not known. No hypertension, anemia, asthma, or cardiovascular disease. Family history, there's no hypertension, heart disease, or thyroid disease. Social history, occasional alcohol drinker and smoker since 13 years old. 5 sticks a day but stopped smoking 4 months ago. Then review of systems, skin, she has brown patches, head, headache, fatigue, and confusion. Eyes, she has blurring of vision, ears, no ringing of ears, earache or discharge. Nose, there are no discharge, and for breast, no pain or discomfort. Chest, there is chest pain. Respiratory, there is no difficulty in breathing. Genital urinary, there is frequent urination. Then muscles, bones, joints, extremities. She has lower back pain, swelling of the ankles, gastrointestinal bowel movement once a day, with no pain, no nausea, and good appetite. General survey, she's awake, alert, coherent, and not in distress. Physical examination, BP is at 110/60, respiratory rate is 20, temperature is 37.1, pulse rate is at 65. Physical examinations, height is 152 centimeters, previous weight was 65 kilograms, current weight is 64 kilograms. Current BMI is 27.71. So, actual or expected PE findings. Skin, she has negative cyanosis. She has no jaundice. Hair is of normal texture with even distribution. Nails are normal in color, no deformities, and without clubbing. Head, normocephalic, atraumatic, no visible or palpable masses, depressions, or scarring. Eyes, anecteric sclera, pink palpebral conjunctivae, blurring of vision. Ears, auricles are symmetric, mobile, firm, and not tender. The pinna recoils when folded. Left and right canals are clear, tympanic membrane intact with good cone of light. Acuity is good to whispered voice. Nose, no sinus tenderness and no nasal discharge. Mucosa is pink, septum is in midline. Neck and throat, lymph nodes are not palpable, no lumps, goiter, tenderness, and no swollen glands. She has no tonsillopharyngeal congestion and no cervical lymphadenopathy. Heart. Through inspection, apical impulse, discrete and tapping. 8 cm lateral to the mid-sternal line. Palpation, regular rate and rhythm. Jugular venous pressure 1 cm above the sternal angle with head of examining table raised at 30 degrees, carotid upstroke, brisk without brutes. Percussion, cardiac dullness on the third, fourth, fifth, and sixth interspace. Inter, interspace. No cardiomegaly or thrills. By auscultation, good S1, S2, no S3 or S4. And she has negative diastolic murmurs. Chest and lungs, inspection, symmetrical chest expansion, symmetrical tactile fremitus, normal muscle retraction of the intercostal space visible in the lower intercostal spaces during inspiration, bilateral respiratory movements. Palpation, no palpable crepitus, no tenderness, no masses, normal lung excursion, percussion, no pleural effusion, normal diaphragmatic excursion, auscultation, no rales or crackles, and no wheezing. Breast, symmetrical, no nipple discharge, no masses. Muscles, joints, and bones. No joint deformities, good range of motion in hands, wrists, elbows, shoulders, spines, hips, knees, and ankles. At the abdomen, inspection, flabby abdomen, normal aortic pulsation, auscultation, normal bowel sounds, palpation, no tenderness or masses, percussion, no tympani with scattered areas of dullness. Genitalia, external genitalia without lesion, and there is vaginal discharge.
I'll be discussing about dental. So, general data of the patient. So, the patient is SDM, is male, birthday February 13, 1998, is 19 years old, and live in 616 Aranga, Sampaloc, Manila. And is a Filipino. And occupation student, civil status is single, religion Roman Catholic, height is 163 cm, and his weight is 59 kilograms. So the patient chief complaint, gusto ko pong magpabunot kasi sumasakit po ang ngipin ko sa bandang kaliwa sa baba na bagang kapag umiinom at nadidiinan, referring to tooth number 36. So, history of present illness of the HPI. So, 1 year prior to consultation, the patient noticed a small hole on the occlusal surface of tooth number 36. So, 4 months prior to consultation, the patient felt sensitivity on tooth 36 whenever he drinks cold beverages, but only lasted for a couple of seconds following the removal of the stimulus. And he noticed also the hole got bigger. 2 months prior to consultation, tooth 36 was broken on the distal lingual wall of the crown when he was trying to beat the candy on the posterior teeth. His tongue consciously felt the spicule that made him feel irritated, and he usually used his finger or a toothpick to consciously touch the broken crown of the tooth. And then, 2 weeks prior to consultation, the patient started to feel the pain. He described the pain as sharp and lingers longer whenever he drinks cold beverages and bit hard food. He rated the pain 8 out of 10, which is the 10 is the most painful. And his mother self-medicated him once with mefenamic acid, 500 milligrams capsule for pain. And then lastly, 1 week upon consultation, patient's mother decided to seek extraction procedure. Medical history of the patient took mefenamic acid 500 milligrams capsule, is not allergic to any drugs, foods, and medication that he known of. He has been hospitalized 5 years ago when he accidentally slept on the edge of the swimming pool, and the mental region area of the skin was lacerated. So dental history, extraction of temporary teeth several years ago, but the patient cannot recall what year. The family history, his mother and father are said to be healthy, and personal social history is not smoker, is not illegal drug user, is not alcoholic drinker. So there are no allergies. So we will go to objective of the dental. So physical evaluation, vital signs, his blood pressure is 120 over 80 mmHg, which is normal. Temperature 36.3 degrees Celsius. Pulse rate 75 beats per minute, and respiratory rate with 18 beats per minute. So extraoral examination, symmetrical face, no TMJ clicking, sound or pain, no swellings, no cracks, fissures or ulcers on the lips, no palpable lymph nodes. He's convex in facial profile. So intraoral examination, fair oral hygiene, pink gingival color, normal tongue position, no elevations, depressions, or color changes in the tongue. So actual or expected physical examination findings. Skin, no cyanosis, no jaundice. Hair is normal texture with even distribution. Nails are normal in color. No deformities and without clubbing. In head, normal, normocephalic, no visual or palpable masses, depressions, or scarring. Eyes, normal, anecteric sclera, pink palpebral conjunctiva, blurring of vision. Ears, auricles are symmetrical, mobile, firm, and not tender. The pinna recoils when folded. Left and right canals are clear, tympanic membrane intact with good cone of light. Acuity is good to whispered voice. In nose, no sinus, tenderness, or nasal discharge because it's pink. Septum is in midline. Neck, throat, lymph nodes are not palpable. No lumps, nor goiter, no tenderness, no swollen gums. Glands, no tonsillopharyngeal congestion, no cervical lymphadenopathy. In heart, through inspection, apical impulse decrete and tapping 8 cm lateral to the mid-sternal line. But in palpation, regular rate and rhythm, tubular venous pressure 1 cm above sternal angle with head of examining table raised to 30 degrees. Carotid upstrokes, breast without roots. Percussion, cardiac dullness on the 3rd, 4th, 5th, and 6th interspace. No cardiomegaly or thrills. No occultation. Good S1, S2, no S3 or S4. A2 to 6 or 6 medium pitch mid-systolic murmur at the 2nd right interspace. Does not radiate to the neck, and negative or no dystolic murmurs. In chest, lungs, inspection, symmetrical chest expansion, symmetric tactile fremitus. Normal muscle retraction of the intercostal spaces visible in the lower intercostal spaces. During inspiration, bilateral respiratory movements. In palpation, no palpable crepitus, no tenderness, no masses, normal lung excursion. Percussion, no pleural diffusion, normal diaphragmatic excursion. Auscultations, no rowels, no crackles, no whizzing. In breast, symmetrical, no nipple discharge, no masses, muscle joints or bones, no joint deformities, good range of motion in hands, wrists, elbows, shoulders, spine, hips, knees, ankles. In abdomen, in inspection, flabby abdomen, normal aortic pulsation. Auscultation, normal bowel sound. In abdomen, inspection, flabby abdomen, normal aortic pulsation. Auscultation, normal bowel sounds. Palpation, no tenderness or masses, normal. In percussion, normal tympani with scattered areas of dullness. Genitalia, external genitalia without lesion, no penile discharge. So, clinical assessment of the offending tooth, number 36, has an intact mesial and buccal walls. The lingual and distal wall is already obliterated by dental caries. So tentative diagnosis of the offending tooth. So pulpal diagnosis, symptomatic irreversible pulpitis, while the apical diagnosis is symptomatic apical periodontitis. So pathophysiology of irreversible pulpitis. So first, the progression of dental caries, it progresses to the pulp chamber. So there will be a persistent inflammatory condition of the pulp. It can be symptomatic or asymptomatic. And then early stage pain when sudden temperature change and continues when cause was removed. In late stage, pain increased intensity and due to patient awake at night. So the treatment could be RCT or root canal treatment or extraction. So the histologic of the tooth affected, so there will be an intrapulpal abscess in the pulp chamber, and as you can see in the black arrow, there are polymorphonuclear cells, infiltration of neutrophils, and then here there in red arrow, fibrosis, and also infiltration of chronic inflammatory cells. So next is the clinical symptoms of the deep caries. The clinical symptoms of irreversible pulpitis. So subjective finding. So sensitive to thermal change, persistent response to hot and cold stimuli, severe lancinating or throbbing pain if intrapulpal abscess formation. Objective finding, increased sensitivity to pulp vitality test, not tender to percussion, unless inflammation is spread to a periapical region. So pathophysia of periapical lesions. So from the pulp chamber, it will progress to the periapical area of the tooth. So depending on the nature and quantity of these irritants as well as the duration of exposure of the periapical tissues, a variety of tissue changes can occur. And then, so pathophysia of periapical of the second diagnosis, the symptomatic apical periodontitis, so from the pulpal. So irreversible pulpitis could be symptomatic apical perio or asymptomatic apical perio. So in this case, symptomatic periapical perio can lead to cellulitis or acute apical abscess. So acute apical abscess may cause cellulitis or chronic apical abscess. So chronic apical abscess may lead to phoenix abscess. So patient chart. The patient has 28 present teeth. So then the treatment plan. So treatment plan: first oral prophylaxis, second diagnostic test of the offending tooth, kit test, cold test, EPT, percussion, mobility, palpation, and test cavity of tooth number 36. Next, surgical removal of tooth number 36, restoration of tooth numbers 17, 16, 15, 14, 22, 24, 25, 26, 27, 34, 34, 44, 45, 46, and 47, and then lastly, patient recall. Thank you.
Gestational diabetes mellitus, new diagnostic criteria.
So gestational diabetes mellitus is a common metabolic problem among pregnant women where there is glucose intolerance before pregnancy or during pregnancy. International Diabetes Federation in 2013 estimated that 16% children born hyperglycemic all around the world. Obesity and lifestyle would be the main risk factor. So the pathophysiology. GDM is when pancreas is unable to offer an appropriate response to insulin to compensate normal insulin resistance, and the GDM is present. This resistance to insulin leads to maternal hyperglycemia, and this stimulates the fetal hyperinsulinemia. However, after birth, GDM disappears immediately. So screening for GDM is carried out by identifying the risk factors. And the risk factors are obesity, increased maternal age, previous occurrence of GDM, family history of diabetes, polycystic ovary syndrome, persistent glycosuria, pregnancy-induced hypertension, history of recurrent miscarriage, unexplained fetal death history, and macrosomia. For the diagnosis, for the screening of the first prenatal consultation, when the result of the fasting glucose is higher than or equal to 126 milligram per deciliter, the pre-existing diabetes is confirmed. And when the glucose and random glucose test, if it is higher than or equal to 200 milligram per deciliter, the patient also has a pre-existing diabetes. Complications related to GDM affect both maternal and fetal health and thereafter child health. A large majority of pregnant women return to normal glycemia after birth as follows. So 2/3 will have gestational diabetes mellitus again in next pregnancy. 20% have impaired glucose tolerance in the postpartum period, and 50% will have diabetes mellitus type 2. So most common maternal complications are risk of diabetes mellitus recurrence in future pregnancies, future possibility of diabetes mellitus, polyhydramnios, pregnancy toxemia, urinary tract infection, candidiasis, higher incidence of premature childbirth, and cesarean delivery. So for the most common neonatal complications, we have hypoglycemia, hypocalcemia, polycythemia, jaundice requiring phototherapy, trauma, shoulder dystocia, respiratory distress syndrome.
For the treatment and prevention, the aim of the treatment is to maintain the normal blood glucose level during pregnancy. A diet with the intake of fibers, especially cereals and fruits, reduce the risk of GDM. Exercise an important role on glycemic control and may prevent, reduce, or delay the need of insulin. The frequency of exercise should be increased gradually, and it is suggested in a 45-minute per day, 5 times a week. So, in therapeutical, we have insulin use in gestational diabetes. Insulin is the first-line therapy for treatment of GDM. Insulin does not cross the placenta-line barrier, providing a safety to the fetus. The choice of which insulin is based on the hyperglycemic pattern noticed during glycemic control. Long-acting insulin is indicated if there is a prevalence of preprandial hyperglycemia, rapid insulin if there is a predominance of postprandial hyperglycemia. So, metformin used in pregnancy. Metformin is an alternative medication for patients with insulin resistance. Candidates for metformin medications are pregnant women ages from 18 to 45 years, gestational age between 20 to 33 weeks, and lower fasting glucose 140 mg per deciliter. So patients should be accompanied by OGTT is oral glucose tolerance test from 2 to 3 months after childbirth. Annual monitoring of OGTT should be annually tested for fasting glucose also. So for the conclusion, gestational diabetes develops only in pregnancy and can only be diagnosed during pregnancy. It does not only risk the pregnant woman but also the baby in her womb. Treatment should be as soon as possible as the diagnosis has been confirmed, and proper nutrition, diet, exercise, right medication should be taken immediately.